your body tries its darndest to send nervous tissue back down there or wake up nervous tissue that has previously not been used, because you do need those signals back and forth, both the sensory and the motor, to get those muscles firing appropriately to send information back and forth from the brain.
You're listening to the Ethos Athletes podcast, where we believe that your health is the number one resource you need to accomplish your dreams. My name is Dr. Matthew Hernandez, and I'm a physician dedicated to helping my patients maintain their active lifestyle and continue doing what they love. I'm sitting down with other experts so that we can provide our listeners with the knowledge they need to improve their health and live their best life. Hey everyone, this is Dr. Matthew Hernandez, and you're listening to the Ethos Athletes podcast. And we are going to be continuing our low back pain series with Dr. Tom Padilla and Dr. Morgan Massingale. For those of you who are just tuning in for the first time, Dr. Tom Padilla is the owner of the Doctors of Physical Therapy here in Scottsdale. And Dr. Morgan Massingale is a physician at Ethos Integrative Medicine. So Dr. Tom, Dr. Morgan, welcome back to the show.
Thanks for having us back.
We're continuing our low back pain series, and this is episode 3 of the series. In episode 1, we went over low back pain myths, and we went and discussed a few of the myths and some of the fallacies behind treating low back pain, some of the common things that people think that aren't actually true. In episode 2, we discussed low back pain that can be caused by mobility deficits. And today we're going to be talking about probably the biggest topic in this series, and that has to do with low back pain due to spinal instability. So let's jump right in. What is spinal stability in the first place? What are some of the things that contribute to it? Now, Dr. Tom, I'll go ahead and let you start with this one.
Yeah, sure. So there are 3 main components that I tell my clients that contribute to spinal stability. The first being bony congruency, the second being connective tissue, and then the third being muscular stability. So with bony stability, you're looking at how the vertebral bodies and the facets fit together. With connective tissues, you're looking at the disc material that goes in between each of the vertebral bodies, and then the ligaments that surround, whether you're talking about the capsule or the ligaments that connect vertebrae to vertebrae. And then you get into the muscle groups, which are primarily the multifidi. You've got these really small rotatoras in your spine. So those are the 3 main components. And so when you're looking at a spine and assessing if it's stable, you're typically looking at bony alignment and bony fit, which shouldn't change much. You're looking at connective tissues and whether they are maybe either lax from a serious strain or sprain. And then you're looking at muscle function and muscle patterns, and do the small stabilizing muscles actually activate correctly with the right timing to hold the spine in place in preparation for movement.
When we're looking at, and we've talked about this in previous episodes, when we're looking at pain or some sort of injury that's coming from a given joint, so in this case, we're talking about the spine, so it could be a vertebrae, different things like that, your outcome of what is causing your pain is typically going to be representative of the type of healthcare provider that you see. So in most cases, an orthopedic surgeon or a pain management doctor is going to be looking at an issue with bone stability or connective tissue. Physical therapists, chiropractors may look at muscle groups, they also look at connective tissue, but oftentimes not all of these are assessed properly. And so knowing the basics behind spinal stability, and that there's 3 different components to it. Again, bony stability, connective tissue stability, and then muscle group is going to be an important aspect in really understanding what's causing low back pain. Dr. Massingale, can you start off with bony stability and talk about a little bit about what can go wrong when we're talking about bony stability in the spine and how that can contribute to someone having low back pain?
When you're looking at bony stability, I think you made a really great point that you can't really look at any one of these things in isolation. You really have to consider how they all contribute to one another and finding what may have been that progenitor tissue that was first damaged that we need to go back and start addressing so that the other things can also resolve. With the actual bones themselves, you have a couple of different things. How are they aligned in comparison to one another? And then the integrity of the bone itself. So if you have any issues like osteoporosis, osteopenia, you're going to need to address those bone density issues. In terms of alignment, you can do kind of the manipulation sort of adjustments like what chiropractors do. There are naturopathic manipulations. I know PTs also do manipulations as well in different fashions, just to make sure that those bones get back into the right alignment and all the soft tissue around it can move appropriately. But then once you put those bones back in place, how do you keep them there? And that's where we really need to think about the different dynamic and static stabilizers that kind of hold those bones in place. Are they functioning properly? Is the tissue integrity correct? Those sorts of things.
So oftentimes I think with the patients that I've seen, and I'm sure y'all in the same case, they received an X-ray or MRI. Usually an X-ray is kind of the first one, and they were told that they have like arthritis in their low back, different things like that. It could be a bony structure that is causing some of the pain, but usually, at least in my experience, this is kind of like the end of the road when it hits a bony trail, right? Or when it hits a bony aspect. There's usually steps that come before that, correct?
Absolutely. One of the best examples of kind of the disparity that you're kind of alluding to between imaging and actual symptoms, I actually go to the knee a lot. When you do post and pre-surgical pain trials, which is what my background was before I went back to medical school, the knee has very specific outcomes. You have x-rays, you grade it on a Kellgren-Lawrence scale, how much arthritis is set in, right? But one of the things that you know and you notice as you work with these patients more and more is that the Kellgren-Lawrence scale doesn't really ever correlate with the patient's pain. You can have a patient with very advanced arthritis that has not a lot of pain. And you can have someone that has significant pain and has pretty clean looking x-rays. That becomes important when you're thinking about how am I going to address this? And you kind of talked about earlier, different professions look at different things, right?
Yeah.
When you're a hammer, everything looks like a nail. So what kind of hammer are you wielding? Are you wielding a hammer that can only address the integrity of that bony structure? Or are you looking at everything else? Another thing that I like to go back to with the knee is that a lot of times you end up with patients with advanced arthritis and they get a knee replacement. And lo and behold, they still have knee pain after they have these replacements. So what's causing that? It's usually the surrounding tissue. It's years of bad muscular patterning. It's years of wearing on the connective tissue, the ligaments that actually hold that joint together, that was not addressed by resurfacing that bone.
I think that's a really important part to make. A lot of people, and we talked about this in the low back pain myths, will really identify with the image that they received. I have a bulging disc, that's clearly what's causing it, and that's not always the case.
Right.
Now, looking at bulging disc and going on to connective tissue, we're looking at different disc, ligaments, different things like that. Dr. Khan, can you talk to us a little bit about what can happen with connective tissue? I think this is something that you're really passionate about because you've been able to help a lot of people that have a quote unquote disc problem. We're able to address that without ever having to use surgery, different things like that. Can you talk to us a little bit about what can go wrong with connective tissue?
What I'll tell most of my clients is that anybody past 30 has some form of bulging in their discs, right? Because discs are primarily made up of water. When you're younger, they're over 70% water. But then as you age, they start to dehydrate. And there are things that cause them to dehydrate at a greater rate, such as being immobile or being in like one position for a prolonged period of time. If you sit with rounded forward shoulders at a desk, for instance, for work for a long period of time, and your spine isn't supported very well, then what tends to happen over time is that's the actual position with the greatest amount of force going through your discs. So if you don't move and allow that fluid to exchange, then your discs start to wear out over time. And as your discs start to wear out, the space between your vertebrae changes. So then you've got muscles that have attached to two vertebrae that have been a specific distance apart for a long period of time. And then those vertebrae are moving closer together. So those muscles are essentially on slack, which creates sometimes a decreased ability for that muscle to stabilize. So then you start to get overactivity of maybe larger muscle groups to start helping to stabilize the spine. And then as that happens, you've got a loose spine, but also on top of that, you've got compression. So that's where you get grinding in the facets and in the joints, which causes inflammation, which causes the capsule to become sticky or inflamed, which doesn't allow the joints to glide past each other any longer. So it's kind of like this vicious cycle at that point. And sitting in flexed postures routinely can also put stress on your interspinous ligament, which is the ligament that connects all the spiky parts of your spine along your back that allows the bones to actually go into flexion and still be supported. And then when they come into extension, there should still be support there. So if someone's in a flexed posture all the time, those ligaments can actually become a little bit more lax and a little loose. And over time, that can cause instability in the joint, which then the body will respond the same way by calling in larger muscle groups to try to compensate for it. And grinding happens. And then the discs continue to dehydrate at a quicker rate.
I'm going to ask you a question when we get to the muscle part, because you brought up a really good point that I think people need to understand. Dr. Morgan, when we're looking at the space, like the compression that he's talking about in the vertebrae, I know this is something you look for on MRIs that often the radiologist doesn't comment on. Like they won't actually go and say that there's an issue with the facet. But can you explain specifically like what you look for and how that can contribute to someone having back pain?
Sure, absolutely. So that's like you said, one of the reasons I like to look at imaging is because I'm looking for things that sometimes radiologists don't think are pertinent. They will definitely always make comments on loss of disc height, if there's any narrowing around the exit of the nerve root, that sort of thing. But a lot of times they don't look at those facet joints unless they are, very advanced degeneration. But with the different weighted images, so most people don't know that there's a lot of different views that an MRI gets you, not only just the orientation of how you're looking at the body, but also the tissues that it's specifically resonating with. So you have a T2 weighted image where it's going to be showing you fat and fluid as bright on the image. And then you have a T1 weighted image. And comparing those two really lets you know if there are fatty deposits, which is showing you more of a chronic issue that the body has started to put fat inappropriately in places to try and buffer some things, or if it's a fluid deposit, which is showing more acute inflammation. And so you can actually go in and hopefully you've gotten a good slice right at that level of the facet to be able to see if there is any fluid or fat that's been changed in that area, and lets you know kind of the chronicity of the issue and kind of how much work you're going to need to do to get those joints healthy again.
And then being able to see that essentially just shows that there's a problem in that area. Does it impact the nerve at all? Like any of the nerves that come out of the spine?
It can. So that joint capsule itself is innervated by the medial branch of that exiting nerve root. And so if you have back pain and you've had a procedure like a radiofrequency ablation, that is the nerve that they're going in and deadening. Unfortunately, those same nerves also have motor components. And, this is directly affects a lot of the stuff that Dr. Tom works with. If they go in and they burn out that motor component, your muscles aren't going to fire appropriately. And so you have a lot of downstream effects from that I don't know that patients are always well informed of before they choose to have these procedures.
Yeah, so going there, let's talk about how muscles contribute to the stability of the spine. And this is where I think we've seen a lot of success in treating patients. And the part that often gets missed right off the bat, and people just kind of skip over this and look straight for either a disc problem or if there's arthritis within the joint, different things like that. And a lot can be done to help somebody if we go and look at the muscle groups. I know, Dr. Tom, you have a whole talk that I've seen you give a few times about the core and how that relates to low back pain and strengthening the low back and all that stuff. Can you talk to us a little bit about what we mean by core, and then we'll kind of dive in from there, talking about muscle groups?
Yeah, so core is a big, just messy misnomer at this point, right? Because a lot of people through time have been conditioned to think of it just as like your midsection. People think that when they do crunches, they're strengthening their core. And it's just over time kind of become this diluted, like nobody knows what it is, right? And with a lot of people, when you first start trying to tell them like activate your core, they look at you with these blank stares because they don't know exactly what that means. Right?
I was doing that.
Yeah. And so over time, people have just gotten a little bit more confused with the core. So when I talk about the core, I'm talking about the deepest core muscles that are responsible for anticipatory control, which means that your body preemptively stabilizes using these muscles subconsciously prior to you doing anything outside of your center of mass, which means that even when you reach forward or take a slight small step, like these muscles should be actively stabilizing the hips and spine at the same time. So the deepest layer of the core is the transverse abdominis, your pelvic floor musculature, your diaphragm, and then your multifidi in the back. And so those things should create a pressure system automatically whenever you are about to move. So they even act immediately before movement. It's part of it. Yeah. It's part of the motor planning process. From there, you should be able to move well, lift objects, exert force.
When we're referring to core and again, spinal stability, what are some of the muscles that you look for in general, or that you often see are weak in people, like some of the patterns that you find?
If we're talking about spinal instability and back pain, what the research has shown is that over 85% of individuals with chronic recurrent low back pain have decreased cross-sectional area and fatty infiltrates in the multifidus muscle specifically. So that's usually the primary culprit in instability for the spine.
Said earlier, one of the ways that if we have weakness within multifidus and other muscles around the spine, some of the larger muscle groups start to tighten to compensate for that and to kind of reinforce what the multifidus is not doing since it's weaker. What muscles specifically tend to tighten up on people that when that happens?
It's really a crapshoot, honestly. Like you get people with completely different presentations. There are lots of muscles that connect to the pelvis and spine, 45 of them. And so it can be the QL, it can be any of the paraspinals or the muscles that connect the pelvis to the rib cage and or the thoracic spine. It could be somebody's hip flexors that tighten up because the psoas connects to the other side of the spine. That's where accurate assessment comes into play. People might present completely differently in terms of like what their compensatory patterns have become, but the root of the issue is still that spinal instability.
And I think we talked about in the low back pain, the same principle where people who are going and getting dry needling or acupuncture or massage or trigger point injections, like whatever the therapy is, into their QL or their psoas or whatever it is, and it's just constantly continuing to come back, and they believe that that's what's causing their back pain. It can be contributing to it, but it's not the root cause of what's happening. It's usually going to be a multifidus issue. And that's what we've been able to see with a lot of the patients that we've co-treated is that aspect. In addition to just pure strength of the muscle itself, there's an issue, or that there can also be an issue with sequencing, correct? Like the order in which the muscles fire. And so that's obviously something that needs to be assessed as well. Can you talk a little bit about what that looks like, what the assessment looks like, or the normal pattern that the muscles are supposed to fire?
Yeah. So, I mean, everybody's born with the good patterns, basically, that develop in their body through time. And then over time with injury or with other compensations, like maybe someone had a knee injury in high school, or maybe they strained their back once really bad. What the brain starts to do is it goes into a guarding pattern with that primary injury. And that pattern, due to what's called neuroplasticity, where the brain learns new behaviors and habits, during that time, the brain starts using the incorrect muscles to stabilize things. And so basically what you're needing to do is switch that back to its correct pattern.
This is where a lot of the exercises and stuff that you do help in correcting, right? There's very specific instructions. And this is why I always tell people to go to PT specifically, because a lot of people are like, oh, yeah, I can do stuff to strengthen my hip or to strengthen my back. But there's a specific sequence that you want and pattern that you want everything to follow. So just going and blindly doing that isn't always in their best interest.
I actually have personal experience with that. So I just recently started seeing one of the physical therapists in your office, Dr. Tom, and I've been strength training with a really great conditioning coach for about 1.5 years now. And there was I had hit a plateau, and I was having some issues and still having some pain. And through working with a physical therapist, I was able to cue me into, this is what it actually feels like when your multifidi fire. This is what it feels like when your transverse abdominis fires. And then I go back to my strength and conditioning coach, and he's like, oh, engage this. I'm like, that's what that's supposed to feel like. That's crazy. Okay. This all makes sense now. I actually shared that with Dr. Jesse last time I was in, but it can make a huge difference even when you don't even realize that you have that deer in headlights. Engage your core. Like, okay, what is that?
Sure.
What does that mean?
And you want to pretend like you know what they're talking about, right? Because you're like, I got this.
Everyone knows what that is.
Doctor, I should know what that means.
Yeah.
What's cool is as people actually, as you restore that pattern, the core is freed up to do the work of the core, which means that the larger muscles are freed up to do the lifting. So a lot of people will get increases in their max reps and endurance and a decrease in fatigability. Yeah, it's cool to see.
Yeah, thank you for sharing that. And we talked about muscle weakness and the multifidus specifically. Like Dr. Morgan had said earlier, there was a study that I recently read, and I'm sure she's more than familiar with, is with radiofrequency ablation and how you can go burn the nerve and stop the pain, yes, but then it weakens. Like that same nerve is what powers the multifidus.
Exactly.
And if you no longer have power, now it starts to weaken and atrophy and kind of waste away.
Kind of double down on your problem instead of creating any lasting healing. But, in all fairness, it does take the pain away. So I get why patients go down that route. But, if you want lasting kind of results, I think you're going to be better off considering some other options.
Yeah, absolutely. So we kind of went over the different things that can go wrong with spinal stability. Now let's talk about what people can do to actually address it. Let's go back to when we're looking at bones, at the bony aspects of the spine. Arthritis being one of the things that can contribute to low back pain. In addition to, I'm sure like facets can go and pinch nerves and do different things like that too. Mm-hmm. Dr. Morgan, talk about that a little bit, and then go and talk about what can actually be done to address some of the issues that may be caused by a bony structure.
Sure. So with like you were saying with arthritis, you're looking really at those articulating surfaces. So where the bones actually meet and have friction. I think most people are kind of aware that those are usually aligned with cartilage that allows that fluid kind of motion of one bone against another. When you have inappropriate compression or breakdown of the stability around those joints, that cartilage is wearing down a lot more quickly than was designed to. And to go in and kind of cause any change in there, you're looking at kind of some higher end injection therapies. You're looking at probably PRP or some autologous stem cell therapies, depending on how advanced and how much that actual arthritis component is contributing to your pain. When you're talking about the facet joints and also down in the sacroiliac joints, if we're talking about low back pain, a big part of the actual pain component is coming from the surrounding ligament because you have a lot of nervous fiber that is in that ligamentous structure. Down in the sacroiliac joint, you have about 70% of pain being generated by the ligament. And, in all fairness, the dorsolateral ligaments are huge, right? They're huge, thick tissue. To address that tissue component, you're looking, I do like my needles. So we're going to talk about some injection therapies again.
Yeah, for sure.
You can consider prolotherapy, which is really great. It's that, a dilute dextrose solution that when delivered into that type of target tissue will cause some remodeling and usually some tightening. Because over time, if you've had any sort of injury, that sort of thing, those ligaments have become lax and stretched and are allowing that excessive motion that's causing that quick breakdown of the joint surface. Now, whether you go straight into Prolo or PRP, or you want to make that grand leap into an autologous stem cell procedure, one has to do with kind of the chronicity of what you have going on, how much damage, how much time, what are we looking at? And then there's also, the financial aspect that a lot of patients need to consider.
How do those therapies compare? We talked about radiofrequency ablation. Mm-hmm. The first step that is typically done in the conventional world is steroid or a cortisone epidural. How does that compare to the therapies that you're talking about?
Yeah, so when you are doing a test for radiofrequency ablation, especially if it's being covered by insurance, you have to do 2 sets of injections prior to doing that. Otherwise, insurance will not pay for it. You have to do a medial branch block with lidocaine, and then you have to do medial branch block with a longer acting, usually marcaine, just to show that those nerves are actually what is contributing to the pain. So there's a certain decrease in your pain score that you have to record for a certain amount of time to show that that's what's going on. When we go down and do injections into a facet joint or into a facet joint capsule, you're hitting the same place. So you're getting down to where that medial branch lives, and you're just delivering a different type of solution. Instead of doing a lidocaine or marcaine, which are both local anesthetics that are just kind of numbing those nerves for a set period of time, or eventually that radiofrequency ablation, which is going down and burning those nerves, you're going to be delivering a solution which is going to, one, decrease inflammation, and then kind of cause some healing to the tissue instead of damage, which is, I think that's a better option, but.
For sure. And when you're talking about, cartilage damage and like arthritis being the issue, the cortisone after a few starts to just worsen, like make that worse and actually breaks the cartilage down faster.
It does. And that is why if you go to a pain management specialist or an orthopedic surgeon, they're limited in the number of times they can dose you with steroids, because it does, even in that model, they acknowledge that, yes, this is breaking down your cartilage. It's worsening the integrity of the tissue. So we kind of have to limit how many that we can do. And that's the long-term issues with steroids. The short-term issues with steroids, you see a spike in blood sugar with steroids.
Right.
Because it acts on those pathways. It's being delivered into the body. It's not being condensed into that tissue. It's having systemic effect. So if you have any existing blood sugar regulation issues, if you're diabetic, something like that, it's going to cause some chaos with controlling your blood sugars for a few days after the injection.
The study that I was reading earlier this week talked about basically how cortisone and radiofrequency ablation don't really have much proven efficacy past 6 months. Radiofrequency ablation, I think, was like in the 30% or maybe low 40% that it's going to last longer than 6 months. I mean, we saw a patient earlier this week that had 4 of them, and
first one's effective and then the subsequent ones aren't. And that's not an atypical picture.
Right.
Like Dr. Tom was talking about just a few minutes ago, you have that neuroplasticity, right? So in the older model of how we thought about the brain's connection to the body, it's kind of like you grew your nerves when you're a baby, and then that's all the nerves that you ever have. And the more we know, the more we know. We know that's not true anymore. Right. If you have damage, you do have the capacity to rebuild nerve pathways or wake up pathways that weren't being used before to kind of recruit and do that same job. So when you go down and kind of deaden those medial branches, your body tries its darndest to send nervous tissue back down there or wake up nervous tissue that has previously not been used, because you do need those signals back and forth, both the sensory and the motor, to get those muscles firing appropriately to, send back information back and forth from the brain.
A lot of people aren't aware of that aspect, and they're not really educated on that part when they choose to go down that cortisone or radiofrequency ablation aspect.
It was funny. I was actually listening to a podcast on the way over here with Sanjay Gupta.
Okay.
And he's a neurosurgeon, and he was acknowledging that, hey, we have neuroplasticity. I was like, whoa.
Yeah.
All right.
So we talked about treating arthritis. We jumped into a bit with connective tissue as far as talking about ligaments and how ligaments can be a pain generator that is often missed as well. Let's talk about the disc a little bit more. Now, what are some things that can be done to support or help improve a bulging disc or even like a disc herniation? Can you talk to what your experience has been with patients that have come in with that issue?
Yeah. When you're approaching any issue, you want to separate cause from effect, right? So the effect is the bulging disc, but the cause may be the muscular compression, or even over time, if your facets aren't mobile enough, then whenever you do flex your spine, it puts pressure at different areas of your disc. So doing things like we've been talking about, which is to inject the facets and clean up some of the inflammatory response that's going on there to get them moving better, as well as reestablishing the muscular patterns that will support the spine and allow the bigger muscles to stop causing that inflammation. Those are the true actual fixes, long-term fixes for the issue.
Yeah, not necessarily just going and removing the disc and spinal fusions and all that stuff. Are either of you able to comment on efficacy of spinal fusions, or maybe the negative outcomes, both or positive and negative outcomes that you've seen for those?
I think it's kind of widely acknowledged at this point that when you get one fusion, you're going to need another, depending on how much life you have left. If you get it later in life, maybe that's not as much of an issue. But for people, a lot of people you'll see start young, and then it'll turn into another one and another one and another one. And that's kind of widely acknowledged by the medical community. So I think that's the primary concern, is that it is a very temporary solution, which in fact, if you think about it, when you stabilize the spine with a fusion, that tells the multifidi that they're no longer needed.
Doesn't need to move in that area anymore.
Correct.
Yeah.
So it reinforces the inactivity of the very muscles that are needed to be active in order to stabilize the spine.
Yeah, and that's a pretty major surgery for a temporary fix, right?
Yeah.
Like that's spine surgery.
Yeah. Yeah, it's a big
it's not
deal.
Insignificant. And, kind of speaking to that same thing, as you fuse one level of the spine, you see increased instability above and below. And that's why you have this progression of needing additional fusion surgeries as you go forward. It rarely is the end fix.
When is spinal fusion surgery given as an option? What typically has to happen for that to become an option?
It's not something that I do. So
Yeah.
I don't know that I'm the best to speak to that.
Everything before that failed. So let's just go ahead and do this.
The only way I've ever done it is if someone is having severe anterior listhesis that's progressive, just encroaching on the spinal canal and dysfunction on, in the lower extremities.
Going back to what we talked about with the disc and going and strengthening or making sure that the muscle stability is in place. We said multifidus is the main contributor to have people with instability of the back that's muscle related, going and getting that muscle to fire and to actually work again is obviously the fix for that piece. Definitely not an easy thing to do. There's multiple things that have to happen before that, and that's all dependent on the assessment. You use blood flow restriction in your office, different things like that. Does that help contribute to allowing that, or what have you found to help that helps with getting multifidus like back to life and kind of working again?
You're asking me for my trade secrets.
Not necessarily.
So BFR, we haven't used it enough in order to be able to answer that question. But what we do know about BFR is that when used regularly, it can have systemic changes that end up with an increased amount of growth factor and things being released to stimulate healing throughout the entire body. There's no research on that specifically. But yeah, so basically what you're looking for are ways to switch the pattern.
Right.
So
And
get the multifidi active again. And once that is accomplished, you can start addressing the other things.
I know on our end, some of the things that we're able to do is, and this is the interesting thing, because and from an injection standpoint, which is when people are coming to myself and Dr. Morgan, conventional world doesn't really have an answer for this part, for going and getting the multifidus working again.
No.
Which is why I couldn't answer that question.
Yeah. and in our case, what we're looking for, or what we do on our end, is we can use an ultrasound, and you can pick this up on MRI too, but ultrasound's what we do in the office. And we can see, we use our ultrasound and run it over the multifidus, and you can see fatty infiltrates throughout that muscle. It usually correlates, like if a patient has pain in L3, L4 region, you can go and ultrasound that section, and there's fatty infiltrate, usually always in that spot, and then even above and below it as well.
Yeah.
Some of the things that we can do, and I'll let you discuss that, and like what we're able to do, and how that helps the multifidus kind of wake back up again.
Yeah. So one of the great things for injections into the actual muscle is platelet poor plasma. So there's a lot of talk out there with platelet-rich plasma therapies, but actually taking that section right off the top where there's not a lot of growth factors or inflammatory components, and injecting that into the muscle belly can help with tears. It can help with remodeling fatty infiltrates, that sort of thing. Some of the non-invasive therapies you can add on to regenerative injection therapies, like gua sha. Gua sha at the tendinous enthesis actually has really good studies showing that it mobilizes fibroblasts. So the actual cells that are responsible for going into the muscle and helping remodel. It wakes them up from where they live, kind of where that muscle attaches right onto the bone. So doing that before and right after injection therapies can actually kind of just add on to the efficacy of what you're already doing, getting those cells woken up and getting them moving. There's some really great studies about caloric deficit. So going into a caloric deficit before regenerative injection therapies to wake up your autologous stem cells. You don't need to then go in and harvest them, but they're more active, they're more awake. And one of the things that we see as we get older is that our stem cells become senescent, which means that they kind of go to sleep a little bit. They stop being as active. They stop running out and doing their job when we get acute injuries. And if you go into a catabolic state before you do regenerative injections and then force the body into an anabolic state, and just by manipulating a diet, you can actually see huge bolster and efficacy of some of the more invasive things that we do.
One of the other things to mention from just more of an overall health picture, as well as making sure that we're looking at hormones and making sure those are balanced.
Absolutely.
We have a patient that we work with on Dr. Tom's team who was going through the injections, going through the PT, and he was improving. But where we saw the biggest jump in improvement was when I went and measured his testosterone levels and noticed that they were low. And so when I actually helped increase his testosterone at the same time, that's when he started making a larger jump in his progress.
Yeah, especially with the older population. If you have women who have gone through menopause, men who are more in an andropause picture, you definitely want to think about that. But you also need to consider that when you have younger females. I see a lot, they've been on oral contraceptive for a large portion of their life that has really tamped down their endogenous hormone production, which is going to play a huge factor in their ability to heal after an injury.
Making sure all like hormones are being checked, all that stuff is going to be huge, and making sure that these patients get better and progress the way that we want them to when they're having these issues. Which, if you're experiencing low back pain, realistically, there's going to be one, if not all three of these issues that are contributing to it. And so getting that evaluated properly is going to be important. Can you speak to some of the patients that we've co-treated and we've used PPP on in order to help get the multifidus or platelet poor plasma in order to help get the multifidus firing again, maybe compared to some of the ones that opted just to do physical therapy? And maybe even before we jump into that, we've used the word fatty infiltrate a lot. Can you explain what that is to people? I don't think we ever actually defined what that was for them.
Yeah, so fatty infiltrate is pretty much what it sounds like. Your muscles get infiltrated by fatty deposits. This is just something that the body does over time when a muscle goes through wasting and atrophy. So it creates an inability for a muscle to generate as much force. And so that's where the issue lies, is you have a muscle that has become weak and underused, so it gets fatty infiltrates, which then make it even harder for it to contract and do its job in the first place. So again, one of these vicious cycle things. So you've got to know where to start breaking that cycle. And sometimes it is with some of these regenerative therapies. Usually in the more chronic individuals who have, obviously chronic means they've had it for longer, but the acute injuries will not have as much fatty infiltrate and or ligamentous instability. So these are the cases that, respond quickly to physical therapy. There are even cases in which, even though chronicity is there, the atrophy is not so bad that the muscle can't recover and start doing its job. But in individuals who are slower to respond to the intervention and the approach, we have found that they have more fatty infiltrates, reduced cross-sectional area in the multifidi, and in addition to that, ligamentous instability in the sacroiliac joint and between the spinal segments. So even though we're reestablishing their motor patterns, they're not seeing the sustained results or not improving at a rate that they would like. So when that has been the case, we have seen really good outcomes with more chronic patients who would like to be athletes again at a higher level. So these therapies have helped them to, and I think we've gone and even seen some post ultrasound images and seen that the cross-sectional area of the multifidi have actually increased in girth. And instead of looking like a flat muscle, it now looks like a round muscle. And it then begins to be able to stabilize the spine. And if we do the regenerative medicine to the SI joint, then now you have a situation in which the pelvis is more stable and the muscles have been more able to be targeted and strengthened effectively. So it's as close as you can really get to a good as new type situation. And part of that depends on how degenerative it has been to the bones and things like that in the first place.
Yeah, absolutely. Is there anything else that either of y'all want to discuss or any other things to leave our listeners with before we wrap up the episode?
Don't let back pain go. It won't get better on its own.
Yeah.
If you've been dealing with it for a little while,
yeah,
it's only going to get worse. And the longer that you go with it, the more degenerative change you have, and the longer and harder of a road you have to fix it. That's all I would say.
Yeah, agree with that 100%. Awesome. We'll go ahead and wrap up the show. Thank you all for listening. On our next episode, we're going to be discussing low back pain due to radiating and referred pain. That'll be one of the final episodes in the series. So again, thank you so much for listening, and we'll catch you on the next episode.
Wanting to look youthful and age gracefully? Our team at Ethos Aesthetic Medicine love working with individuals who want natural-looking results with minimal downtime. Our Ethos Glow approach is designed to help you show up as your absolute best self by giving you brighter, more even, and youthful-looking skin. Ask our team how you can get more information on our Ethos Glow approach to achieve natural-looking results that make you shine.